Hey everyone, I am so glad you tuned in. This is the first interview that I am doing with the master of the specialized liposuction for women with lipedema. You've all heard about him because you know Pale Ginger Pear, Cara Cruz, talk about Dr. Jaime Schwartz. Dr. Jaime is what she calls you. Is that what I can call you?
Absolutely.
It's so nice to have you here today. Thank you so much. Did I introduce you correctly?
I think so. Yeah.
Okay, cool.
Yeah.
So is there a special name for the kind of liposuction you do?
Well, the liposuction portion is the lymphatic sparing liposuction. And I think we've still even taken that to a different level with the specialized portion of it. And we're even looking at it as we operate and watching, even with an ultrasound, to kind of see the areas that we're doing and making sure we stay away from the lymphatic areas. But that's only part of it. And that's probably sometimes even a smaller part of it. More of what we're doing now is more of a manual extraction to really remove the nodules that people have. And by doing this, we're getting out, when you take that area out, that's where you're getting out the inflammation and not creating more fibrosis and scarring. And you're seeing people really just do wonderfully with that.
We've heard from Cara about how the pain, it's not just about reducing size, it's about eliminating pain. Those fat nodules are so painful.
They are. That's actually like we'll call it the epicenter. That's actually where everything's happening. And so if you don't get that out or treat that, I don't feel like you're actually truly helping people with this. And we've seen that time after time. You know, we've even had people where serendipitously, or we've actually been able to complete, let's say, one limb with the extraction and one limb without, due to like bleeding or something like that. And we found that the part that we didn't treat without the manual, it's almost like we didn't treat anything. Even if we've done a couple liters of liposuction, it's not really treating what the actual issue is.
How did your career, now I know you've got a vast background, but how did you end up, and I know you do a lot of other things, but you are a renowned expert with regard to lipedema. How did your career end you up here?
Um, it was it was a little well, I won't say random, but what I'll say is, so I was recruited to California by a hospital system. I built a plastic surgery department and a breast reconstructive program. It's a huge system. We had 5,000 employees, multiple centers, things like that. And we were self-managed HMO. And of course, what you find out over time is that it's actually better to treat people with weight loss, gastric bypass, than it is to pay for diabetes and high blood pressure. Not even pay for it, but it's actually better. We're more of a community hospital. We didn't have gastric bypass doctors, so the endocrinologist and I that was there, we kind of came up with a little bit of a different plan. He was doing a lot of medical weight loss management, and so I started doing actually large volume liposuction, mainly like to the abdomen and stuff like that, to really deflate people, to allow them to kind of move on. And we found it was actually working really well for people. We weren't doing gastric surgeries for them. When you take out weight, it was actually kind of jump starting them in a lot of ways. Of course, you had to be on the right mindset. It couldn't be just laying in bed and I'm going to do this for you. But we found a lot of people were losing a ton of weight. And then we had a subset of people that really weren't losing in their legs or arms. And this is before I really even knew about lipedema and really knew about or really understood this. And then over time, I happened to get introduced to the wonderful Dr. Karen Herbst by a friend of mine who worked with her at the university. And it kind of all came together that way. So it was really like I said, it was kind of just like a not backwards way, but it was a circuitous way of getting into it. It wasn't something I was really looking for. We were just looking to really help people in one way. And then it's kind of gone in this direction. And so.
That's what I hear about you over and over again, your genuine heart to help people. And that's why you are beloved by the community. And I always do this disclaimer in every interview. What's right for one person may not be right for the next. Surgery isn't for everyone, but I know a lot of you are truly interested in Cara's surgery and finding out more about this. So Dr. Jaime, who is a good candidate for your particular type of liposuction for lipedema?
Well, to be totally honest, we're starting now to look at prospective studies, and we're really going to look at, because our outcomes have really been astounding to us also. And there really hasn't been like a subset of people that are better or worse for it. I feel like if you're treating if you're treating that, you need to treat it that way. And so it's not like one person's better than the other, but what we're finding is that no matter what you do, you got to treat it the right way. That's the best way to really explain it. But yeah, I haven't found one person better than the other. At some point, Dr. Herbst knows this about me too. I don't believe in the stages. I don't think this 1, 2, 3, 4 makes sense at all. I think it's rudimentary. I think it just looks at skin quality. It doesn't do anything really. I think as we advance with lipedema and our understanding of it, we're going to start looking at pain is really the reason I treat this, of course. And so we have to start looking at pain. We have to start looking at distribution. And then I think eventually we're going to come up with the actual different subsets and rather than just a stage of how the skin looks. And so, because I can keep talking about that, but I always say, I have some people that come in with stage 1, we'll say, and they have excruciating pain. You have people that come with stage 3 and, they don't have as much pain, but obviously there's more fatigue. And so it's like, how do you decide one person over the other? So
that's another whole interview. You're absolutely right.
I think a lot about this. I spend a lot of time thinking about this. So.
Well, anytime you spend time with Dr. Herbst too, you know that you're on the cutting edge of this, and cutting edge, no pun intended, but you, I feel like we're at an exciting juncture of breakthroughs.
Yeah, I think we are too. We're starting to, rather than just saying, somebody has lipedema and we don't even really have an exact, actually after this we have a meeting with an insurance company to start going through these exact things and what our criteria are and stuff like that. So rather than saying that, yeah, somebody has it and we're treating it, we have to start looking at really get more specific with it. And we're starting to, part of the thing that the manual extraction has done is we're actually looking at the nodules now. We're making the incision a little bit larger. I'm actually looking at the fascia and looking at what we see internally with people. And it's a wonderful world, we'll say. I mean, because what people think, and you hear this all the time. And I know like lipedema is very grassroots, there's chat rooms, a lot of people try to help each other, which I think is great. But what you think externally and you say, I have fat and it's painful and just remove it. It's not as simple as that. The body is a lot more complex. There's different layers, there's different areas, there's a lot more that goes on inside. And so I think that I think we really need to understand all those different layers and exactly why we're doing something. I always say I will never operate or do anything until I understand why. And that's how we kind of got to this point also. Lymphedema and lipedema they're not common, they don't start commonly, but they do kind of end commonly. And I think that's why we treat it similarly. But I do think it's important. I mean, look, I've had people that are starting to develop, we'll call it the stage 4, like in their feet. And after the manual removal, their feet have even like, they don't, I mean, they still have lymphedema, but it's almost gone. Like they don't really need a lot of compression. And Kara, actually, I didn't even think about it. Kara actually said that too, but I've seen that with a lot of people. And so there is something that we're doing well without hurting lymphatics. Dr. Herbst has actually changed my thought process because, like I said, working together, she understands things and I understand things. And so I always used to treat the stomach last for people, especially when people are large. I would do the extremities and then come back and say they're going to lose weight. Dr. Herbst's thought is that you should actually get to the stomach earlier rather than later because the pannus is pressing on like lymphatics and really actually blocking flow from the legs. And actually, she's changed my thought process. And now for a lot of people, as we're giving them like their surgical plan, the stomach is either first or second in my surgical plan. If somebody's legs aren't as awful, but their stomach is really bad, I'm starting with their stomach and I'm saying, let's get all this out. A lot of it's lipedema anyway. I'm taking up 20 pounds sometimes. And they're allowing people to really, it's not pressing. If the legs are really bad, then we'll start there. But I think getting up to this area is really, really better for people. It's the pressure part, of course, out to the aesthetic part. Taking out that massive amount of weight also starts taking weight off the joints. It allows people, this is a byproduct that I've learned by doing this for a while now, is that compression fits people better too. If I make people's legs a third of the size they were, which I do, and then their stomach is out to here, I can't even get them compressed. So It actually all goes together. So Dr. Herbst is right, and then now we're embracing that. Is that we treat the stomach earlier on, and you know what would be interesting to look at also is treating the stomach, looking at the legs, including using compression and Lympha Press, and seeing how that how that does better too. Because I think that's what you're going to start seeing. I think it all goes together.
I think that this component of marrying the surgery with the pneumatic compression has such great possibilities for great outcomes for these patients.
Yeah.
So I would love to see that. And I think it should be, when people think surgery, you mentioned stages, it's rarely just one surgery, correct?
Yeah, it's really hard. It's plus the other reason why it's I'm really I don't use the word aggressive. I get everything out. So it's a bigger procedure than people realize. And so I think that's why it's more than one surgery. Actually, I just operated on a lady. It was a revision. She went to Germany by a very, very famous doctor there. She had 3 surgeries with him. She was there for 12 weeks. I won't even tell you what the cost was. I did as much in one surgery as she had done in 3. And now, again, because of that, recovery is a little bit harder. It takes a while but it's like she's fully treated now. She doesn't need more. And so that's what we're seeing with things.
So exciting. So what makes your approach unique? Let me ask it that way.
So if you look at it, I'm from New York, so I talk with my hands. So
And I'm
I use
Italian,
this.
so I talk with my hands.
There you go. See, we're the. So I would say I would do this with patients. I would say if you look at this, you look at like your hand here. We'll do this. This is your skin at the top. This is your muscle at the bottom. So there's a lot more that goes in between than just layers of fat. There's the best lymphatics are down here. There's another layer of fascia here. There's all kinds of and all the nerve and blood stuff's down here. So there's a lot more that goes into it. So sort of the lymphatic sparing liposuction portion is, as I'm doing the liposuction, it's actually staying just up here. I'm not getting down deep into the muscle. And actually, I'll tell you something about that in a little bit. But we're really staying up here with it. The nodules and where all the fibrosis and or the deeper stuff is really down below that area. And that's the stuff we're massaging and getting out. So I'm not, the cannula is not getting anywhere near this bottom area at all. So it's, and I think that's what people have to understand. There are anatomical differences. Yeah, and I've seen a lot of, I'm doing a lot of revision surgeries from people from in the US and outside. And I've seen some pretty, and like I said, I think people just randomly doing this is not the way to go. But the problem is also, liposuction is one of the most common procedures that's performed in the world, especially in the US, because there are people that just think we can just do this even tomorrow. They take these weekend courses and like, oh, we're just going and sucking some fat. You have to understand the body's really, really different. It's not even the stomach. Like if you have to understand every area you're operating on and why you're doing something and where it is, otherwise you're not really helping people. And so even from the cosmetic aspect, you really have to understand what you're looking at.
I want to get back to your point about getting deep into the muscle, but you brought up the word cosmetic. And I talk to so many women who, with tears in their eyes, say, I got denied for coverage because it was deemed a cosmetic procedure. And yet these are women, some that are bedridden, that can't walk to their mailboxes. They can't have anyone touch them without it being so painful. Does that kind of get you riled when you hear a response like that?
Not only that, it upsets me to a lot of different levels. And I've had patients that I've had a nurse, let's say, that she was in California doing a rotation from Texas, I think, and the doctor here, a doctor wouldn't clear her for surgery because he doesn't believe in lipedema. I have doctors that will write letters for the insurance companies that just say exactly the things you say, and I wind up calling them personally and talking to them and saying, and so I think it's really more of an education type thing, but it is a challenge. That's part of the reason why we meet with the insurance companies. I've had fights with some of the medical directors, and I've had to write letters myself, and I try to use the word malpractice as much as I possibly could because, it really is a true thing. And I think it's a very, very difficult, for people just to say, oh, somebody has large legs, so we're not going to do this for you.
So is the key just education then, educating the medical community and the insurance providers about the realness of this, and how do we do that? How can we help? Because we sure care about that too.
Yeah. Well, I'll tell you, actually, to go back, once you use liposuction with an insurance company, it's game over. So I actually developed a breast reduction we call LipoLift that's done with liposuction. Liposuction for me is a safer way of removing breast tissue. You leave nerves and blood vessels and lymphatics behind. So this is from a long time ago. And whenever an insurance company would look at the claim, they'd say, well, you did liposuction. And so then I'd have to talk to the medical director and say, I'm removing the tissue. Why would it matter to you if I'm doing liposuction, which is actually safer, or I'm opening an entire breast and cutting and randomly cutting and closing things? Why would that matter to you? And then eventually they would approve stuff. But that's the whole thing. We had a call with the heads of United Healthcare. I think this was a couple of years ago, and I realized that as we were on the call, that when you keep saying lymphatic sparing liposuction or liposuction, they just basically don't want to hear about it. We've changed our terminology. Everything we do here is called it's called lipedema reduction surgery, because that's what I'm actually doing. To the insurance company or to anybody else, it shouldn't matter if I'm using liposuction or my manual technique but that's what we call it. And because some people, it's 80% liposuction, 20% manual. A lot of other people, it's flipped around. It's very little liposuction, and it's really the manual getting everything out. So it really shouldn't matter which way I'm doing it for people. So
that is a great distinction. Our words are very important in how we frame things, because there is a predisposition to say, well, liposuction, that's cosmetic, but lipedema reduction surgery. So that's the phrase really to use. So you talk about the liposuction part of it, but sometimes it's primarily the manual component. What is that technique? I mean, what kind of nuance is involved with doing this so carefully?
So the way to look at it is why it wasn't so careful. I always look at what happened. So this was a bunch of years ago. I was taking care of a lady from Washington State. I think it was Seattle. And we were removing the lipedema from the back of her calves. And I did the lymphatic sparing liposuction. And when I finished, you feel like, I call it the pebble garden. I mean, everything's still left over. So I tried taking the liposuction cannula as gently as possible and try to remove them. And I actually wound up giving her some skin necrosis, like a wound on her skin. And so we're friends now. She still walks. She walks a billion times better. Like people have healed perfectly. But that wasn't the issue. The issue was I was trying to figure out how to do this, because everybody just says, if you talk to people that say they do this, they just say lymphatic sparing liposuction. There's really they don't really explain what they're doing or how they're doing it or why they're doing it. And actually, now that I'm seeing patients from other people, even from years ago, you can see that I don't think they really were doing it. So we started thinking, like, how can we get this out? And I'm pretty sure the next patient we operate on, probably even the next day or that day, probably a week later, if we saw that, we started taking my hands and trying to massage things. Then we started taking my liposuction equipment and doing it, and I've bent everything I own by now. And then, I started looking at even like how people do it, with deep massage techniques and fascia, and we even there's a lot of like Chinese ways of doing things. And so I've looked at every single thing, and now we actually have it down to a science where, it's actually like it's part of our normal process, and it just gets people in and out. And what's interesting is, though, like I said, when you do that, you see people even the next day, they say their legs feel more mobile and lighter, and people's arms a week later, they're like, before surgery, they're like, I can't hold my arms for 30 seconds. A week later, they're like, I'm good now. So there is something with it.
How gratifying is that for you to see those kinds of results?
It's really, really happy, not only for me, but for all of us here. You do this because you really want to see that. You really want to see that change with people, and you hear it all the time. You hear, I couldn't walk for a mile and now I did 4 miles, or, I couldn't keep up with my kids for this, and now I can, even go to their soccer games and do more. So you hear this with everyone. It's gratifying, as it makes it happy, but it also means that we're doing the right thing. And I always think doing the right thing is the most important.
And so you've got so many success stories and some very high profile ones. I have to imagine that you have to be so careful with that manual extraction. And you mentioned being careful about protecting the muscle.
So I have one of my saddest stories is a lady I'm taking care of, and she was sent to a doctor who said he does liposuction and wanted to start getting into lipedema, and she's in her, I think her mid or late 30s. And when I saw her as a consult for revision, she actually has problems walking right now. She walks with a cane, and we started looking into that. And I was examining her. It seemed like her, I use this as the foot, her muscle was just really tight. So I got an MRI because my suspicion was that they didn't liposuction the lipedema, but they liposuction her muscle, and actually that's what happened. So we got the
Oh,
MRI results, and it looks like and the reason you're starting to see this though is not only that the muscle's deep where you want to stay away from, but Dr. Herbst and I are now looking as we kind of even open up people, and you'll see that what lipedema does to even the fascia, especially the deep fascia, is that fascia is a thick connective tissue. As this keeps happening, it keeps breaking it down and replacing it. So the fascia gets really, really weak here. So a lot of people see like their muscles bulge. I think it's one of the theories why people say they have problems walking, because if your muscle's not being held together, it doesn't work as well. And so I think it's very easy to go into the muscle with liposuction. So we've even seen, as we've actually opened people up, where we've even seen some hernia areas where without even touching people, the muscles started bulging through. So that's what I mean. I don't think we don't completely. I understand why I knew I was never going to go down here with liposuction. Now I understand even more why, and I think we're still learning this. But I mean, these are brand new things that have never really been discussed or talked about, and so I think we're getting there. But I think that's the reason why it's not just I'm going to start doing liposuction for lipedema tomorrow, or I think you really have to understand what you're doing and why. And then even the manual technique, just so you know, I mean, it's we call it massage, but I mean, there's some areas, and I can point them out. I can look at them in 2 seconds on people that, I mean, it's like fully embedded, and we have to do even, have to be a little more aggressive isn't the word, but when you get things out, it feels a ton better. But you have to still be careful because it's a very thin skin. There's a lot going on, and so it's not that simple with any of it.
so there are people out there that have been diagnosed and they are researching surgery. What should they look for when choosing someone to do this work for them?
I honestly, I try to stay out of that conversation,
Okay.
because it's not, I think when people ask that question, I think people try to, they'll say themselves or they'll talk. I think for me, I think the most important thing with anybody before you ever have surgery is, meet the doctor. Of course, you have to feel comfortable with someone. And that sounds weird, but we
No,
have the same thing.
this is very
Yeah.
drilled down because there's a lot of great marketing campaigns out there
Yeah.
and
Yeah.
visuals and painting a commercial photo. And this is no
Yeah.
joke, which is why I'm asking the question.
Yeah, we have the same thing. I mean, we have, we know, and I hate going this direction with it, but we know there's chat rooms. We know there's people that pay their patients and coordinates. We don't. I stay out of every little aspect of it. Just say we don't get involved in any of that stuff. People always say we're not putting up certain photos or certain things like that because they want to see all these perfectly round leg results.
And when you're looking at your cosmetic marketing, certainly you have those smooth, perfect photos, but that's
Yeah.
not the picture you're trying to portray with
We
lipedema.
have the people that, and what's interesting though is the people that were starting. I see every aspect in our practice, but I will tell you, the huge percentage of our practice is the stage 3, stage 4 people. Even though I say the stages, but the people whose legs are twice the size of their bodies. Anybody who says they treat lipedema really, really don't want to do that, or take care of that. And so yeah, that's the people we're taking on the challenging, really the challenges that are here. And so, and that's, yeah.
I know that your time is limited, so I just want to ask a few more clarifying things for our lipedema women watching right now. You say you see a lot of people when they get to the later stages because at that point they're pretty much desperate for help. What can you say about the progression of this disease and taking action early?
So I think we'll say the conventional wisdom, the consensus when you talk to like, like the people we all were, Dr. Herbst, Dr. Eicher, myself, like when you look at this, obviously the consensus is the earlier we treat this, the better. for a lot of reasons. One, when you're younger and healthier, we can do a lot more and get things out. And of course, it's usually, hopefully, before times of hormonal changes where you start before pregnancies and before things like that. So that's one of the things. But the honest answer is we don't know about the progression. We can't say because somebody's stage 1 at 16 years old and they get to stage 4 at 60 years old. So you don't see that also. But then again, you see some people that have these monster legs in their 20s and they don't even know where they came from. So again, it's some of the stuff we really don't understand. So I think the safest and best course of action at that point is to say, treat it as early as possible. And I think that's sort of how we look at these things. But in terms of progression, we see it, but I can't give you exact things. And I can't say that person's going to 100% go to this way. And you don't see everybody that has these monster legs doesn't always get lymphedema. In fact, lymphedema is a really small aspect of it. The problem with the lymphedema diagnosis is that a lot of people go to or refer to lymphedema centers and told they have lymphedema. And then even when I see their photos and talk to them from anywhere in the world, I say, you don't have lymphedema. But so I think that's a lot of the confusion that goes into it. But.
Well, I'm excited about us surmounting this learning curve in the community. And I am so appreciative of your time. One of the things I do have to mention is Cara used the Lympha Press Optimal Plus before and after her surgery. So the impact of pneumatic compression, can you speak to that with your patients and its efficacy?
Yeah, what I can say is we all like compression, we all like massage, we all like those things. I think if you can obviously have a machine that kind of does it all in one, and you're getting like a consistent result or from it, I think it's a really good thing to do. I think when we see people, what I tell people is the top 3 ways to treat lipedema. These are the secrets out there. Everybody write this down. Ready? Number 1 is compression. Number 2 is compression, and number 3 is surgery. So those are I say that on purpose because compression, lymph press, all these types of things, that's really what we see is best. And I'll tell you, the reason is it's not lymphedema, it's not even the fluid movement so much, but what you're seeing is, what I tell people is lipedema is an inflammatory process. The reason for compression, all these things is like athletes wear compression to decrease the inflammatory process, recovery thing, stuff like that. People that wear compression, people that do lymph press, people that do those things, you will see a decrease in the inflammatory process. Their nodules will be softer. They'll be less painful. It makes surgery easier for both of us, I say. And so I think those are the things to really look for. So I think that's the stuff. Again, those things aren't going to cure it, but even if you can stabilize and make it a little bit better, I think it makes everything easier in the long run. So that's the way I look at it. And
Thank you for speaking to that. We are talking about managing this condition so people can get back to living. And so with time running out, is there anything I failed to ask or something you want to leave our viewers with? This is the Lipedema Channel and it's TLC. We offer tender love and care, and we want to uplift the community. So you have the platform for the last stab at this interview. Go for it, Dr.
Honestly, there's no real for us. We really want to advance this in a lot of different ways because I think we have to get a better understanding in order to progress, not only for the treatments, but also to get insurance coverage and everything. Actually, let me go back to that for 1 second. The problem that we're seeing, we're getting a lot more people covered. I mean, even on our own, like we've got a great system now, and there's great people out there trying to help, and we're doing this. But the thing is, though, we still have to show efficacy. So we still have to show that this is making things better. So just by going and getting something treated, if it doesn't work, and then you go back to the insurance company and say, well, it didn't work, we're going to hurt ourselves in the long run. So that's what I tell people too. So be very careful about, it's a community. We're all working together here. So that's what we're trying to do. We have to show that everything we're doing, which is why we're studying it, that what we're doing works, that it's making people better, that they can hold their arms up, walk more. That's how we help each other out. And so, and the more understanding we get, the better we're going to wind up doing. So.
Dr. Jaime, I can't thank you enough for helping so many people and giving us of your time. I know you are in between patients. Thank you. We hope to have you back again at one of our roundtables. You have an open invitation.
Thank you.
And I want to thank all of you for tuning into this edition of the Lipedema Channel. We will see you next time. If you know someone who would make a great interview, send them my way. My email address is right on the screen. You take care and have a great day. See you, everybody.
Everybody, thank you.